Nick did most of his training up in the Chicago area and then Minnesota, and he was the division chief at University of Chicago for quite a few years. He's well known in the GU world, has basically one of the founding fathers of CLGB cooperative groups, now resides in Nevada, works with US Oncology, where he's the vice chair of research, and will present for us a summary of GU tumors. Welcome, Nick.
So we're going to talk about genitourinary cancer from ASCO, and I'm going to cover renal cell and then prostate and then bladder. So I would say overall it's not been it was not a stellar GU year, but there were gaps that were filled in. The biggest debate among almost everyone doing renal cell carcinoma is, do you use pembrolizumab or do you use nivo/ipi? And there was no new update on nivo/ipi, but there was this update on pembrolizumab. Would remind you that this trial was randomized against sunitinib in the 4-week on, 2-week off. That's probably not the best way to give sunitinib, but nonetheless, it was randomized against that, and it was pembro. And the data confirmed, and this is now slightly updated, so maybe slightly different numbers. The objective response rate to pembrolizumab is 60%, sunitinib 39%, but if you look overall at any regression of tumor, it's 94% with pembrolizumab and about 89% with sunitinib. So these are highly effective drugs in a very hormones in a very sensitive disease population. Now, the overall survival remains impressive. Hazard ratio here is 0.69 with a p-value of 0.001. And we're now looking at 24-month data. This was published in the New England Journal of Medicine at around 18 months, as I recall. So we have a good, consistent overall improvement. Now, there is debate about favorable risk patients. Favorable risk patients are those with the kidney having been removed, with no biochemical abnormalities such as anemia or hypercalcemia or thrombocytosis. As you can see, the response rate is a little bit better with the doublet, but the overall survival is not different. And the PFS is beginning to show a slight advantage, but as you can see, there is no tail on the doublet therapy yet. So still for the favorable risk, which only accounts for about 15% of these patients, pembrolizumab could be an alternative, a bit more expensive, of course. The intermediate and poor risk patients are where the debate about nivo/ipi really comes into the fore. And last year we saw that in the favorable risk, these nivo/ipi were identical to sunitinib, maybe a little bit better with a fewer longer duration responders. So this data from nivo/ipi is not here. This is pembrolizumab. And for both groups, the intermediate and poor risk, and for overall survival and PFS, there remains an advantage for the pembrolizumab. One of the new things that Dr. Klimak did was look at the question of what is a CR? We always wonder, there's a small lesion left in the lung or something left in the liver or maybe a slightly enlarged node, and you wonder. So what she did was she looked at landmark analysis, all survivors at 6 months, and then looked at the degree of response, complete being complete, 80 to 100%, 60 to 80, 30 to 60. And what you find is that if you look at CRs in the pembrolizumab compared to the 80 to 100 with pembrolizumab, they are better in pembrolizumab than with sunitinib. So this suggests that there is a degree of improvement. Meanwhile, there are those patients who have less than 80%, 60 to 80 or 30 to 60, and you still see some benefit, but again, this post hoc, a little hard to get too excited about this. But the 80% or greater may be a new way to analyze response in this population. So now with longer follow-up at 24 months, pembrolizumab continues to have an excellent overall survival rate and hazard ratio of 0.68. PFS remains very good. Overall response rate is improved over sunitinib, and the complete response rate is gradually going up. And if patients are considered to have an 80% or greater response rate, confirmed, this suggests these people could, and we haven't yet asked this question, come off study and be observed. So the debate will continue. Nivo-Ipi means that you have to keep them on axitinib and pembro, two expensive drugs, whereas with Nivo-Ipi, you may be able to stop therapy. We saw that last year with Dr. Tanik, with Dr. Nazir. So potentially, the Nivo-Ipi remains a better choice because you can stop the drug. And even if you get an immunotherapy toxicity, those duration of response rates or the duration of response remains very high. So this was a look at the Nivo-Ipi question, and it asked in a phase 2 whether there was any advantage to doing Nivo first and then trying to salvage with Nivo-Ipi. This was run through the Hoosier Cooperative Oncology Group. And there were a lot of questions when Nivo-Ipi was approved, like what about monotherapy with Nivo in both naive and in non-clear cell patients? And what about salvage? If the patients could or could not have been salvaged with Ipi. So there was a lot of biomarker questions as well. This study was phase 2, it was only 159 patients. The non-clear cells, the 36 patients were not included, so it was 123 clear cell patients. And the question about the Nivo-Ipi really didn't get answered fully. There were only 34 Nivo-Ipi patients because a lot of patients in the clear cell cohort either went off treatment or were still responding or died. So we don't have a clear answer. What we did learn was that Nivo by itself has some definite advantages. Here's the overall cohort. 24% had favorable, 65% intermediate, and 10% poor risk. But they reported that Nivo monotherapy, similar to pembro monotherapy, which had been reported several years ago by McDermott, did induce complete responses in favorable risk disease, a little less in intermediate, and no complete responses in poor risk. So the overall response rate was in this 31% range with pretty good confidence intervals. So for a select population, Nivo monotherapy could be then used first line. And you see here the responses in the favorable risk were quite striking. Almost everyone responded. And likewise, at the right side of your screen, in the poor risk population, a very high response rate. So the battleground really gets fought in the intermediate, and there's still a large number of patients shown in the red bars, who don't get long-term response to any of our drugs, either Nivo-Ipi or Pembro-Axi. And those are very disconcerting patients because they're the most common subtype, almost 60% or more are there. So when they did move on to Nivo-Ipi salvage, the progressive disease, most of the patients had progressed on Nivo, and only 34 patients were enrolled. Other selection criteria were in play. 34 were evaluable, and of those 34 that were evaluable, there were no CRs, and the PR rate was relatively low. So they concluded that the Nivo monotherapy is surprisingly effective, particularly in the favorable and even in the poor risk, but that the salvage does not salvage. So Nivo-Ipi does not salvage, except a small number of patients. So not a preferred strategy. And we should, if we're going to do Nivo-Ipi, probably just stick with Nivo-Ipi. As the second bullet says, higher response rate, longer PFS, more complete responders, and lesser burden of disease in a number of patients who have immunologic toxicity. There are other ways to look at this question. They presented another poster and paper, which I listened to, which doesn't change the opinion. Basically, Ipi Nivo later does not salvage these patients. So this is my list of top clinical advances in renal cell that I presented at UCLA GU meeting the other March. And I had 7 lists, and this continues to be number 1. Namely, we have Nivo-Ipi or Pembro-Axi showing survival advantage. The debate is still ongoing. You can argue it at different levels, depending upon whether you're a pure immunotherapist or whether you like to do a TKI. There's arguments both ways. Interestingly, avelumab, axitinib, and atezo-bev were not reported. They did not show a survival advantage and have not yet been FDA updated, although atezo-axitinib did show a PFS, so it's FDA on label. No survival advantage, though. There are other doublets and triplets that are coming. Nivo-Ipi-Cabo looks very promising. Nivo-Cabo looks promising. And Pembro-Lenvatinib looks promising. So we'll expect those to be updated in the next year or 2. Pembro, Nivo, Cabo, and Lenvatinib are all active in non-clear cell. And remarkably, the sunitinib and pazopanib utilization has dropped off the map. I gave a patient pazopanib 4th line yesterday, and I sort of had to remind myself what the right dose was. It's been that long since I've used the drug. So we have a new one coming, tivozanib, and Carmina still supports nephrectomy after sunitinib. There's trials underway that are looking at nephrectomy in Nivo-Ipi, and I think that was surprisingly to some of us, showing almost a complete response in the primaries after Nivo-Ipi, again supporting an immunotherapy combination. So in the prostate world, we have the FGF, the PET F18 scan. There are 2 competing PET PSMA scans. One is a gallium, and the other is the F18. The gallium is the one I'm using with UCLA. It's close, the patients can drive and get it. F18 has got some advantages. It's probably going to be cheaper. It's a little bit more portable. And so this trial looked at the utilization of F18. The study was called Condor. Now, previous data have suggested this PSMA PET is superior, and that the F18 now looks like it's better regulatory, easier to transport, doesn't require generators like gallium does. So Condor is FDA mandated, if you will, or at least designed in collaboration with it. And here is Condor. It is strictly for rising PSA in the non-castrate population. The companion trial is called Osprey, and it has two cohorts. Cohort A, which is for clinically localized disease, to see whether it changes the approach, and Osprey cohort B, which requires biopsies to confirm the PSMA positivity in a variety of locations. So Condor has what we call a composite truth standard. It would have been better if we have been able to do pathology, but that's very hard because by definition, these patients don't have measurable lesions on standard imaging. So the F18 molecule is a lysine-linked urea-based small molecule, so it's targeting the extracellular domain. It's very easy to give. It's a relatively lower dose of radioactivity. It's still 9 microcurie or millicuries, and your imaging is done quickly, 1 to 2 hours. And the eligibility in this Condor trial were the PSA had to be less than 2, over 2 if you had radiotherapy or cryosurgery, but it had to be over 0.2 if you were radical prostatectomy patients. And they had to have negative scans on CT, MRI, bone scan, PET, regular PET, or flu cyclodine, could also be the choline. So this is a very critical point because we commonly get the anxiety, the PSA anxiety goes through the roof when your PSA hits 0.2, and you tell patients, look, imaging just doesn't help. So they could not have been on hormone therapy, and they could not have been in any other systemic therapy. So the standard of truth is an interesting concept. It is not what we would consider a learned document. It's not like the Bible or the Quran or the Torah, but it is a composite standard of truth. And this means that if you could get a histopathologic finding, that would confirm a scan. If you could get an informative conventional imaging, or if your PSA dropped after radiotherapy. Sort of an interesting composite. Here are the baseline characteristics. I won't bore you with those, except to say that the median PSA was 0.8. So this is well below the range when normal bone scans and CT scans are helpful. Also point out that the over 68% of the patients had a PSA less than 0.2. So you can imagine this is a challenging population where we don't have a lot of good imaging ability. And each of these bars stands for readers. There were 3 readers, and each one of them said yes or no independently of one another, and then they used it to compare to the standard of truth. And at low PSAs of 0.5, on average, 36% of patients were identified as having disease. And if you look at the far right side of the graph, for the patients that had a PSA of over 5, 96% of patients were identified with very high correlation among the readers. So this is a remarkably sensitive test and opens up a lot of questions about what do you do when you detect disease. Is it really non-castrate sensitive metastatic disease, or should you radiate? So then they talked about how this changes management. And it was well done. 63% of patients had a change in management. Now, most of them were, if the disease was identified, that is, it was a positive. If it was a negative, they also used that. So we're getting more and more comfortable now. We don't know quite what a negative scan is, but we're getting more and more comfortable acting on the basis of the PSMA scan. So you can see the major categories. Non-curative systemic therapy was changed to salvage local therapy. So radiation oncologists are seeing a slew of these patients. And likewise, salvage local therapy, which we would normally have considered, has been changed to systemic therapy, usually with ADT. And there was a significant number of patients who were under observation who were then initiated therapy. And there were a smaller number who were planned to have treatment who were elected to undergo observation. So a pretty nicely done study. Condor then met its primary endpoint, picking up very early metastatic disease in men with biochemical relapse, BCR. It yielded actionable information in about 70% of patients. And this trial, combined with Osprey, will soon, I believe, lead the FDA to approve this in all of our practices. We should be able to get this marker soon. In the remaining section of prostate cancer, I'm going to talk about the 3 trials, all of which were reported at ASCO, of those 3 drugs, enzalutamide, apalutamide, and darolutamide, all of which showed now a survival advantage. We've all been a little bit nervous about this because we had a non-survival endpoint, which was metastasis-free survival. Gora Sternberg led off with this one. This was published previously by Maha Hussain in the New England Journal of Medicine. Osper took patients with castrate levels of testosterone, a PSA over 2, no findings on conventional imaging, reminding that this was conventional imaging, and randomized patients to enzalutamide or placebo. Safety and other endpoints were reported. Here we have their overall survival. The median is reached. Enzalutamide is 67 months, placebo 56 months. Not a gigantic difference, but certainly clinically significant. That's almost a 10-month difference or it's a little bit more than a 10-month difference. Hazard ratio 0.73, p-value 0.001. So the use of subsequent therapy after enzalutamide was fairly well balanced. Abiraterone was 49 to 59%. Chemotherapy in the same range. Enzalutamide was crossed over in some patients. Cabazitaxel was not well used. Not sure why that drug should be used more heavily. Bicalutamide was used a bit. The time to subsequent therapy shown here, 19 months for placebo, 66 months for enzalutamide. So during that time, the cost of drug is there, but not the cost of any other subsequent therapies, which is borne by the placebo group. One of the ongoing criticisms of enzalutamide is this fatigue, fall, mental cognition issue. They now report more of a normalized rate. This is 100 patient year rate. So you see the fatigue is not quite as significant. Musculoskeletal events more common with placebo. Falls are double still. This is still an issue about CNS events. So 4 per 100,000 in placebo, 9 per 100,000 in the enzalutamide, and cognition still slightly elevated in the enzalutamide treated patients. No other worries, although there was a slightly increased risk of ischemic heart disease that needs to be at least thought through. So Dr. Sternberg concluded that patients with non-metastatic treatment, non-metastatic disease, enzalutamide reduces death by 27%. It prolongs survival. Adverse events are still there, haven't gone away, and we'll continue to deal with those. And this paper was published in the New England Journal of Medicine. And Cora moved back from Italy, where COVID was an epidemic, to New York, where it was an epidemic as well. So And next time I see Cora, I'll blame her for the transmittal of COVID. We saw an update from Dr. Fizazi on darolutamide. This left me a little bit unsatisfied because we don't. We have a study like darolutamide against placebo, with the primary endpoint being met, namely metastasis-free survival, and there was a trend in overall survival. This is now the. Can you hear me all right? Yeah, good. This is now a overall survival endpoint, and they report also pain to progression and cytotoxic chemotherapy. So the overall endpoint is not reached in either group, but statistically those curves will no longer cross. Hazard ratios 0.69, p-value is 0.003. We will not be able to compare their actual real world, if you will, median overall survival to enzalutamide. So those numbers are real, and we don't have to worry about this. For secondary endpoints, time to pain progression were met, 25 months for placebo, 40 months for darolutamide. Time to first cytotoxic chemotherapy improved with darolutamide, and time to first skeletal symptomatic event also met. So we have with Aramis a benefit that appears consistent, namely there are fewer side effects. And although you can compare and contrast these, Dr. Fizazi did us a favor and highlighted the falls, which do not appear to be in excess with darolutamide. The fatigue does appear to be a little bit greater with darolutamide, and the rash is a bit greater, 3% all grade versus 1.1%. Hypertension, slightly elevated, some cardiac arrhythmias, but these did not go into any highly significant numbers. But again, the AR blockers are giving us some side effects, no question about that. Okay, seizures not seen, mood impairment disorders not seen. All right, final analysis, no negatives, improvement in survival, although the numbers didn't actually make the 50% mark. We have a 31% risk of death. We have a delay in cancer-related morbidity and mortality. We have to do chemotherapy less frequently. Skeletal symptomatic events, namely requiring radiotherapy, were reduced. And with extended follow-up, the side effects remain very favorable, although there was a slightly longer interval in measuring darolutamide side effects than there were with enzalutamide. So this is published in New England Journal of Medicine. Now, the Spartan trial was only on a poster, so I extracted this from the poster. Spartan was apalutamide, 240 milligrams a day, randomized 2-to-1, metastasis-free survival was present as the primary endpoint, and it met that primary endpoint. We now are in the overall survival. The thing I like about the apalutamide is that we have real numbers. We're not projecting anything. The apalutamide median survival is 73.9 months, rather stunning number. Placebo was 59.9 months. There was the study opened when it met its primary endpoint, and some of the placebo patients immediately went over to apalutamide, and so they are shown in the gray bar of the gray line. But this isn't something that I haven't quite understood, namely that apalutamide mandated or unless you went off study, you got free enzalutamide, you got free abiraterone. And here we have numbers that are rather impressive in terms of the overall. Look at that, APA, 70 months. The same thing holds for symptomatic progression, PSA progression, shown on panel B, and this one is PSA progression in C. So very dramatic. And the last is, what's the last one there? That's PFS2. So take a look at PFS2. PFS2 meant that you progressed on placebo. You then got a very good drug, abiraterone, that gave you a 41-month survival. And yet there was still a further improvement in apalutamide improvement. So it does lead me to think that potentially further androgen receptor blockade does improve your survival. Can't prove that yet, but certainly suggestive. So we have these 3 drugs now, and here's my top 10 advances in prostate from March, and I've updated number 2 to be in red. It certainly is a big step forward for PSMA. And now we can say under number 5 that Enza, APA, and darolutamide all improve overall survival. The winner looks to be apalutamide, interestingly, with a mandated secondary androgen receptor blockade. Whether that's the case or whether there's other issues is unclear. Darolutamide didn't come up with an absolute number, it came up with a statistic for us. So now we're moving on to bladder cancer, and Maha Hussein and a bunch of very well-respected bladder cancer experts did this study. It was a high-risk muscle-invasive bladder cancer, radical cystectomy or a nephrouterectomy with a lymph node dissection. They had to have a pathologic YPT4 to T2 or T4, could have to have positive nodes, randomized to atezolizumab or observation, a classic, almost a perfect study design. Reasonably good follow-up, and unfortunately, the trial was negative. Rather disappointing, 400 patients. Hazard ratio, maybe 0.85, but those curves cross, and maybe, but nothing to say yet. Maybe atezo will have a longer tail. We'll see. It's still a little early. The median survival of metastatic bladder cancer that occurs after a cystectomy is about 80 months. So we're not yet at the end of this, and the absolute overall survival has not been reached, but it doesn't look promising right now. It didn't matter whether it was PDL positive or PDL negative. There was no hazard ratio favoring either one. So they concluded that it's the first adjuvant trial. It's consistent. I didn't show you the toxicity. You're all familiar with the toxicity. There were definite side effects. So this regimen should not be recommended. Pure adjuvant checkpoint therapy should not be recommended. This trial did not meet its primary endpoint. The primary endpoint was disease specific. So it's possible that OS may be met. So for now, we shouldn't use it as a routine adjuvant. The plenary session had Tom Powell's study. Again, the outstanding investigators are shown here. Many of them contributed greatly to this study. The background, of course, is that there's a variety of PD-L1, PD-1 inhibitors that are approved for second-line therapy. But it turns out that only a minority are actually getting this, whether this is resource-constrained environments. In the United States, I don't think that's true, but it certainly is the case in many places outside of the US and Europe. So avelumab is one of those 5 drugs approved, and they designed a trial of giving chemotherapy first and then giving avelumab maintenance. So the patients could go into this study with either a CR, a PR, or stable disease. They could either get 4 to 6 lines of treatment with either cisgem or ciscarbo, or carbogem. And avelumab was every 2 weeks, not easier, kinder regimen, but nonetheless, that was the label. And the primary endpoint was overall survival. And it met that overall survival dramatically so, with a p-value and a hazard ratio, as you see, with a 21-month improvement with the avelumab and a 14-month, 21-month overall with avelumab and 14 months with best supportive care. At 18 months, you can see the statistics: 61% versus 44%. And the PD-L1 positive patients had even a better benefit, but the PD-L negative population did not experience a less impressive benefit. So you don't need to worry about the subset that's PD-L1 negative. The overall population, when you looked at the residual patients with partial, there were patients who went from partial to complete, or people who were in partial or stable disease going into higher grade responses. So there was a higher response rate as well with the avelumab. So they concluded that its Javelin Bladder 100 met its primary endpoint, giving an overall survival in the overall advantage in the overall population and PD-L1 population. The overall survival was longer with avelumab, and it didn't matter whether you gave cisplatin or carboplatin-based regimen, or if your response was a CR, PR, or stable disease. The avelumab was typical checkpoint inhibitor therapy. I didn't show that data. And it was, the only drawback is it's every 2 weeks. So this is now a new standard, if you will, for follow-up after induction chemotherapy for metastatic disease. Previous data from that Matt Gelsky has published in the Lancet suggests that the combination of chemo and atezolizumab may also be a preferred approach, but that is not yet covered by most insurance companies. So, and advances of bladder cancer, we still, this didn't quite make my top 5. Erdafitinib is still a very impressive drug. And enfortumab is really a dramatic improvement for some patients. Pembro for BCG refractory CIS, checkpoint inhibitors for the Lynch syndromes, and there's the long-term CR data that keeps coming out. So those are still the top 5, but the maintenance of avelumab now is a pretty big advance. And the addition of checkpoint inhibitors to gem and a platinum is still not mainstream. We'll see more of that later. And whether the checkpoint inhibitor prior to cystectomy or to replace cystectomy is still a very open question, certainly being done more and more. So thank you, Ralph, for inviting me. I appreciate the time. Sorry I was a little late, but it's good to be here, and thanks again for inviting me. Happy to take any questions.
Okay, well, take any questions. If anyone has a question, feel free to type those into the chat box, or let me know if you want to unmute yourself, and we can definitely take some questions now.
I'll unmute myself because I'm not a fast typer here. Nick, just a question on the diagnostic. Do you think that, I guess the question always is with trying to identify disease earlier, when it's just basically otherwise would have been normally PSA rising. even though it did change management in a fair number of folks. The question is, do you think we're going to see subset advantages? Like, for instance, the more, it'll make a bigger impact on the folks with the, shorter doubling time, right?
Yeah, it's hard to know. Hard to know. Biology still trumps imaging. Imaging is still following behind the biology of the disease. There is, no proof yet. The Oriole trial was published in JAMA Oncology about a month ago, and they did a randomized trial, radiation of oligometastatic disease or no radiation. They radiation oligometastatic disease and appeared to show PFS advantage. Overall survival is still pending, but they did build into it a PSMA scan. And interestingly, the people that got PSMA scans where the lesions were not radiated had a very rapid progression, requiring ADT much sooner. So I think we're going to see a variety of these studies. It's a little hard to design them because they're expensive. The PSMA scans are expensive. But I can imagine that if we can detect nodal-only disease and low-volume nodal disease and radiate that, we're going to see some impressive survivals. The natural history of the disease, though, is that it's a long, slow slug. So we're going to probably not see a lot of data coming out very quickly. This will be over the next 10 years before we get answers in some of this, particularly in the survival question.
Great. Thanks, Nick. Appreciate your time.
Thank you again for inviting me. You'll have to have this.
We do have one more question. Would you please elaborate a bit more on FGFR inhibitors? There are many in development. What is your experience with them, and which one would you like to see approved in bladder? Oh, we lost your sound again. Oh, we still can't hear you, Doctor. I don't know if you can hear me.
Looks like we lost your audio, Nick.
Yep.
Oh, there we go.
There we go.
Okay, good. Yeah, it's a strange audio on Zoom. I'm getting to dislike that part of Zoom. All right, what was the question?
Sorry, would you please elaborate a bit more on FGFR inhibitors? There are many in development. What is your experience with them, and which one would you like to see approved in bladder? Oh, we just lost you again.
Well, Nick, we lost your audio again. Maybe if you can either type it on the chat or email Carmen, and Carmen can forward it to the person who asked the question, I guess.
Yes, we do have another question after that one. So I don't know, Dr. Vogelzang, if you feel comfortable typing it in, or if you prefer, I could email you the question and we could have a response for the people who asked the question. No. Okay. Well, thank you all. We'll try to get your questions answered at a later time. I'll try to email those out to Dr. Vogelzang, and we thank you again for coming and presenting.